Welcome to this edition of Forks and Things. My name is Joshua Dilday. I'm on the Education Committee for the AASD Associate Membership. And today we are honored to have Dr. Brad Chernock and interviewing Dr. Matthew Martin on a very relative and very important clinical decision tree and algorithm. Dr. Martin not only is the immediate past chair of the Western Trauma Association Algorithms Committee, but he's also the Chief of Emergency General Surgery at Los Angeles General Medical Center and University of Southern California. He is going to be joining us discussing the Pediatric Emergency Resuscitation Thoracotomy Critical Decision Algorithm Review, which is a joint effort between Western Trauma East and Pediatric Trauma Society.
So the objectives and methods as outlined in the algorithm, one is create a decision algorithm and procedure guide for pediatric emergency resuscitative thoracotomy, that a detailed systematic review and practice management guideline using the GRADE methodology. The GRADE practice management guideline was actually under separate cover published by East. And the methods were, there was a working group between East, Western Trauma, and Pediatric Trauma Society. They conducted a literature search via PubMed from 1975 to 2021, found 110 references. And based on those references and expert consensus, the algorithm was developed. Dr. Martin, would you mind walking us through the algorithm? I'm going to focus on who this is appropriate for, when this is appropriate, and how we're going to go about executing this algorithm. And then at the end, we can talk about a couple special considerations.
All right, sure. Happy to do it and happy to be here. This was a great project because I think the collaboration between the three organizations, and I'd recommend anybody who reads this one to also take a look at the East Practice Management Guideline on the same topic from our work group. So we always, when we talk about pediatrics, the first question is, well, what do you mean by pediatric, or what's your age cutoff? For this algorithm, it's less than 15. We've seen many studies that have used a cutoff age of 18 or even 21 as quote unquote pediatrics. And what that does, it gets you a lot of essentially young adult patients and very few true pediatric patients. And the age of 15 from the literature is about where there seems to be a reliable break point in terms of different outcomes between the less than 15 and older than 15. So this algorithm starts with a pediatric age patient less than 15. And then the initial branch point is, did they lose vitals or have arrest? And do they have signs of life? And signs of life, as you show here, we defined as narrow complex EKG, spontaneous respirations or movement, or organized cardiac movement on ultrasound. So we start with the vitals on arrival. And so this part of the algorithm is for the patient who did not arrest pre-hospital and does not arrive pulseless. And so immediately you might say, well, why would I do a thoracotomy? But we do have some patients in that category, even though they have vitals, they are in profound worsening shock and are essentially in the peri-arrest status. And you'll particularly see this in kids, and they'll usually manifest that peri-arrest status by going from severely tachycardic to bradycardic. And so if they go to severely bradycardic or a profound shock, and we have that table that has the age group vital signs that indicate shock, then we would recommend performing an ED thoracotomy if indicated, rather than waiting until the patient arrests. If they do not have profound shock and or bradycardia, then obviously it goes down to the standard trauma evaluation workup. And if they do, then it goes into the assess the area of body injured and whether it's reasonable to proceed with an ER thoracotomy. So this is now the other side of the algorithm. This is for the patient who did arrest in the field and or arrives pulseless. And the first branch point here is whether they have any of those signs of life on arrival. And if they do not have signs of life on arrival, and this is where our algorithm really, I think, differs from the adult algorithms, as they treat a blunt and penetrating differently. Essentially, for children who arrive with no signs of life and no vitals, we generally do not recommend proceeding with an ER thoracotomy, regardless of whether it's blunt or penetrating trauma. So as you can see here, after signs of life on arrival is no. Then it goes to, do they have a severe head or brain injury? If yes, then we recommend terminating resuscitation immediately. If they do not, then we recommend standard medical resuscitation and treatment as a PEA arrest to look for immediately reversible causes. And if none are found, then again, we recommend termination of resuscitation. If they do have signs of life on arrival, then we do recommend all the initial resuscitative interventions, such as intubating, chest tube or needle thoracostomies, control of any external hemorrhage, and then proceeding on to the next branch point, which is looking at the body area that's injured. So when we again recommend ER thoracotomy for blunt or penetrating truncal injuries, but generally only if there's signs of life present. And then ER thoracotomy can be considered even for the patient who is not in arrest and who hasn't lost vitals if they have profound shock and truncal injuries. So this is the next part of the algorithm where the patient does have signs of life, and then you quickly assess the mechanism and injury pattern. So if it's penetrating or blunt head injury, we recommend medical resuscitation, TBI management, but do not recommend ER thoracotomy. If they have penetrating or blunt truncal injury, which would basically be chest, abdomen, pelvis, then we recommend proceeding to ER thoracotomy. And if they have penetrating or blunt extremity injury, we recommend medical resuscitation and extremity hemorrhage control measures, but do not recommend ER thoracotomy. So this is the second figure of the paper. And this is really just a procedural guide that kind of takes you through step by step performing a standard emergency resuscitative thoracotomy on a child who meets an indication. And it also has the table on the right that is just some pediatric dosages for fluids, blood products, medications, pressors, ACLS drugs that would commonly be used in this scenario. So the procedure guide starts with, obviously, they've met criteria. We recommend a large left anterolateral thoracotomy with immediate simultaneous adjuncts of a right chest tube and NG or OG tube placement and initiating transfusion if it hasn't already been started. The first thing we want to look for is a large left hemothorax. If they do have it, we want to evacuate that hemothorax, control the hemorrhage. If it's a massive lung or hilar injury, then clamp the lung hilum if necessary. If they don't have a left hemothorax, then we want to open the pericardium to assess the heart. And then you'll see that dotted line going to the bottom. That is for the case where there's a large bleeding from the right-sided chest tube, where we recommend extending to a clamshell. And these are performed simultaneously if you have evidence of large right-sided bleeding. So after opening the pericardium and assess the heart, if there's tamponade or cardiac injury, yes, then we go to repair or temporarily control the cardiac injury and move to the OR as soon as possible. If there is no tamponade or cardiac injury, then we look for organized cardiac activity. If there is none, then we recommend terminating resuscitative efforts. Although, as we mentioned there, you can do a brief period of open cardiac massage and pediatric life support resuscitation if a medical cause is suspected. If they do have organized cardiac activity, then we recommend clamping the descending aorta to improve central perfusion and continuing resuscitation with blood products. And then again, that box on the bottom is if they have a large right hemothorax, we recommend the clamshell thoracotomy and then dealing with whatever you find in the right chest, just like with the left chest. Now, if none of those have been positive, so you've done that, you have no thoracic source, you want to evaluate rapidly for a abdominal or pelvic source. If you have an abdominal source identified, which would usually be by a fast exam or a diagnostic peritoneal aspirate, then we recommend moving to the operating room for exploratory laparotomy, hemorrhage control, and removing the cross clamp as early as possible. If there's a pelvic hemorrhage source, then again, we're moving to the operating room for preperitoneal packing or angioembolization if there's a hybrid OR available, and with placement of a pelvic binder. If there is no truncal source identified, then we recommend continuing the trauma evaluation and resuscitation, and the goal is to remove that aortic clamp by 30 minutes. So some additional considerations, again, as I mentioned, the age cutoff of about 15 years appears to differentiate the outcomes. And this is likely reflective of the lower overall blood volume of pediatric patients, as well as their better ability to compensate for hemorrhage. So when these kids go into arrest, they generally have exsanguinated because they were able to compensate so well. So they are in a much sicker state than adults. And this is different than most areas of trauma where we think of being more aggressive in kids because they have better outcomes than adults for most types of injuries. Actually, in this scenario, they have generally worse outcomes if they've arrested. And so it is somewhat counterintuitive, but you actually want to be a little less aggressive with pediatric patients who have a traumatic arrest. If there aren't any signs of life on arrival, you can do a rapid search for immediately reversible causes like a tension pneumothorax or cardiac tamponade. And if none of those are present, then terminate resuscitation. And ER thoracotomy should be used in selective circumstances. In general, we don't recommend it for severe TBI or for extremity injury that's caused traumatic arrest, but there are some selective cases where it may be indicated. And then we get into a couple of ethical considerations, and these are also present in adults, and there's generally two of these that are usually encountered. One is doing an ER thoracotomy, even in a patient who you know is not going to survive, to try to salvage an organ donor. And that's a whole separate discussion of whether we think that's ethically acceptable or not. And there are pretty good arguments on both sides. The other ethical issue that comes into play is doing these mainly for training purposes or education. And again, that's a long ethical discussion, but we do want to have surgeons who are familiar with the procedure and able to do it rapidly when a salvageable patient comes in. So again, I think there is an argument for the teaching benefit, but the controversy comes in of doing it purely for education. And then I think one of the most important things, especially for anytime you've lost a child in the trauma bay, is we always stop, have a moment of silence, and then you should have a timely team debrief, because these events can be really hard, not only on the trauma surgeon, the residents, but also think about the nurses, the medics. Sometimes the family is present, and these events can be really hard on them. And even a short debrief and letting some people recognize the loss can help a lot with some of the adverse emotional effects of these events.
Thanks, Dr. Martin. That's really very helpful and a very interesting and useful algorithm. Just to summarize the key points, the emergency resuscitative thoracotomy in pediatric population really does have dismal outcomes, and pediatrics was defined as those under 15, so that is where there appears to be a demarcation in outcomes. Decision tree is based on whether there are any signs of life. If there's no signs of life, then there's no emergency resuscitative thoracotomy. And the signs of life are similar to those used for adults, being movement, spontaneous respirations, narrow complex EKG, any cardiac activity on an ultrasound. And if those are present, then you proceed down the algorithm. Profound shock is an indication for pediatric emergency resuscitative thoracotomy, keeping in mind that vital signs are different based on age group. And profound shock is also noted as a pediatric patient with profound bradycardia and a source of hemorrhage. Location of injury determines branch point toward emergency resuscitative thoracotomy or medical resuscitation, external hemorrhage control, etc. So once again, thank you very much, Dr. Martin. Really appreciate your time. And here are some resources for further review.
Thank you so much, Dr. Chernock, and thank you so much, Dr. Martin. This was a wonderful review of an unfortunately very relevant algorithm. We want to thank you very much for your time. Look forward to the next Forks and Things. We'll see you next time.